I want to redouble on thanking our speakers, because more than half of them are actually traveling from very far away, and it's pretty late where they are right now. So the purpose of this session is to give a platform to providers of data for all of us to look at COVID-19 mortality and differences across populations. And so part of the discussions will be a presentation of this data, and then the other part will be to discuss issues in reporting death in real time, which is what everybody is trying to do right now to inform scientists and policymakers, and how these issues create problems when we try to compare population across countries or within countries. So the three presentations will start with Arianna Caporali and Emmanuelle Cambois from INED, who will talk about a database developed by INED to present international data on COVID-19 mortality by sex and age. Then we'll have a presentation by Vladmir Shkolnikov from the MPIDR. Vladmir is also the founding director of the Human Mortality Database. And we have added weekly death counts as a historical series for multiple countries to the HMD to support research on COVID-19 mortality. And the third presentation will be by Farida Ahmad, from the CDC, who will more specifically discuss data from the US. So you each have 15 minutes, and we will start with the INED team, and Arianna will present first.
Yes, so thanks a lot for inviting us to, I need to share the screen for the PowerPoint.
Yes, so
yeah,
you should be able to.
It says that it is deactivated.
So I have to find you. Okay, here you are.
There, I just activated it.
Okay, so
okay.
you are now,
you.
now share your screen.
So can you see it?
Yes.
Yes.
Perfect.
So once again, thanks for inviting us to this seminar. We'll present this website and database, the demographic of COVID-19 deaths, which was launched by INED about 2 months ago. I will start with the objectives of this project and the data, the description of the data that we provide. And then Emmanuelle Cambois will continue with the presentation of the key research-related issues linked to the data. So this is a collaborative project. Here you have on the slide, you have the members of the team. There is people from INED, but also from outside INED. Our objective is to provide cumulative counts of COVID-19 deaths by sex and age for cross-country comparisons. We aim to contribute to the understanding of this data for accurate analysis of the pandemic. We want not only to inform the research community, but also policymakers, institutions, and journalists about the quality and the comparability of this data. Therefore, for us, it is very important to provide well-documented data. In particular, it is necessary to trace the data and qualify the national sources, which implies description of the national procedure to collect the data, as well as the definition of the data coverage. There are 3 key data characteristics that can impact the data comparability. First, the places of death, with the distinction between hospitals, institutions, and home. Second, the causes of death. COVID-19 can be confirmed in laboratory or suspected. It can be the main cause of death or not. And third, the dates of death, with the distinction between, for example, the publication, the registration, and the occurrence date. Since we want to extensively document our data, to include a new country in our database, for us it is necessary not only to have death counts by age and sex, but also to describe the national data sources. And we also want to have an in-country expert who provides us with the data in case this is not publicly available, or who validates our data and metadata and helps us contextualizing and interpreting the data. So far, we provide data for 13 countries, those in green in the slide. In the forthcoming weeks, we will also include the 6 countries in yellow. And for the countries in orange, we have established contacts with country experts. For the available countries, we provide death counts by sex and age groups, total number of deaths, sex and age combined, if possible, death counts by places of death. And there is heterogeneity across data sources and countries as to width of age groups. For most countries, we have 10 years age groups, periodicity, daily or weekly data, the way in which COVID-19 is identified, it can be suspected or confirmed, the main cause of death or not, the coverage of the data as to the place of death, hospital, for example, hospitals, institutions, home, and the reference date, for example, publication, registration, or occurrence date. For each country, there is a dedicated web page with a link to the data file and explanatory notes, summary information to describe the content of the data file, links to the data sources, and links to download all the documents and used to as data and metadata sources. So very rich documentation. The data is provided in Excel spreadsheets, such as this one. In this case, for England and Wales, we provide data by sex and 5-year age groups. We also provide the population structure by age and sex. So there is a sheet for each data source and a metadata sheet to inform to provide key information on the data. For additional information, we recommend to carefully read our explanatory notes that are structured in 5 paragraphs. First, the indication of the data sources. Second, the coverage, whether the data include only hospital deaths or all deaths. If available, if possible, we describe the cause of death certification process. Third, we also describe the data collection method, that is the protocol followed to report the deaths. Depending on the source, it can be a methodological surveillance system, recording of hospital activity, and statistics on death by cause. Fourth, we indicate the collected data, that is the information available for COVID-19 deaths, for example, sex, age, date and place of occurrence, geography, and comorbidity. Fifth, we have also the countdown stop time, namely the time at which the death count is stopped before the publication. Among the ongoing developments, there is the creation of pooled datasets and of a metadata overview, of which here you have an extract. This table will show all the rich information that we provide, and it will also be a useful tool to identify comparability issues. So I will now give the floor to Emmanuelle.
Yes, thank you, Arianna. So we provide the data, but we also provide a lot of information, and there are some comments on the chat that are quite challenging comparing those data. And so all the documentation that is provided is to highlight how careful we should be when we compare. So we provide also 7 key issues related to the data comparability and quality. So you can go through these issues, and I'm going to present some of them today. Basically, we highlight through these issues the potential, but also the limitation of the data when we want to compare them and use them. I'm going to just go through very quickly across 4 of these points, which are the problem of death dates, the problem of place of death, and how you compare countries or within country data. And also, I saw that some comments about these age patterns of COVID death. So if we go to the first point, we know that what is reported by the countries each day and the difference between the day before in neither all nor only the death of the day. Indeed, you very well know, everyone, that's between the occurrence of a death and the date of publication in national reports, there are few weeks, few days. It depends on the process. So in France, for instance, the paper process takes between 3 weeks or 4 months. Electronic pathways are very quickly, but then we have to be aware that on one day you can have not all the deaths that already occurred, and the deaths of the day also comprise the deaths of the previous days. So in our database, you can have some countries, actually 4 out of the 13 we already documented, that have the occurrence date and publish the occurrence dates. That means that each day they process what they call the backlog to reassign the death according to the date of occurrence. And so you can see that the daily counts change day after day according to this reassignment of the death. So one point is to be aware of what kind of data you use and whether you have the date of the death or the date that are known on the day of the publication. Another issue that we go through is the place of death. So Arianna explained that we've got some statistics covering hospital deaths, institution, home, and sometimes only one of these particular places is documented somehow because of the way the data are processed through the path I just talked about. So for instance, in France, up to the beginning of April, only the death in hospital were published every day, because that was where the data could be processed in quasi-instantaneously. And so they didn't have any information about death that occurred in a nursing home, for instance. This occurred in the beginning of April, and this is the curve on the top, and you can see that it was worse, taking into account this death in a nursing home. Of course, this is a big part of the issue of COVID death. So again, we provide in the database what kind of data coverage is in the file that you can use. And if we look at the share of these deaths in France, for instance, you just found out that today around 60% of the COVID death occurred in hospital, and 40% in institution, and mainly institution for the elderly. Interestingly, you can compare the different countries. Here you have England and Wales, and you can see that the share of death in hospital is a little bit larger than in France, but you can also see that they report in England the death at home, which represents approximately 5% of the total COVID deaths. We also have this information for the US here, and you can see that even more of the deaths by COVID occur in hospital, according to the statistics, and a little bit more at home in the US than in England and Wales. Another information coming from France, which is interesting, is that part of the deaths occurring in hospital actually is death of people that are the residents of elderly institution. And it's not neglectable. You can see that 12% of the total deaths occur in hospital, of COVID deaths occur in hospital by residents of institution. That makes the interesting point that half of the deaths by COVID in France are actually death of people living in institution for elderly population. A third issue that we wanted to document it here is whether we have to look at what happened in a country or in a region. So this is very well known that there are clusters and not all country is affected by COVID. So here the map for France. France, we are very concerned in 2 regions, which is around Paris and in the east of France, northeast. And you can see that these regions are really affected, and other regions in France are really scarcely affected by the COVID. Here in this new graph, you can see the daily death in different regions of Europe and also in Hubei. And finally, you can see in this graph that the region of the country are somehow closer. Here you can see in the graph Brittany, which is the lowest affected region in France in this graph, with the region of Italy. And so some region in different countries are closer than region within the same country. So next I will go quick on this one because it's a table showing the different population and COVID share of across France. And if we go in the next one, so everything is in the website anyway. Here we have the age and sex differences. You can see that, of course, we know that mainly the older people are concerned by the COVID death. You can see that there is a sex ratio with a big disadvantage for male, except at the very oldest ages where the sex ratio is favorable to male rather than female. And if we look at the age pyramid now, here at to date of the pandemic, the day 28 and the day 45, and you can see again that there is quite a similar shape across countries. Here in France with most of the death in the oldest ages, but here you can see in Italy, for instance, that has a long life expectancy, that there is a kind of deficit of the oldest old if you compare to France, which is an interesting point to discover because maybe it's a lack of data covering this age group. And you can see in Germany, finally, that they were in the case of Italy at the day 28 of the pandemics, but then there is a catching up, and at the day 45, they recover a kind of a good representation of the oldest old in the COVID death. So finally, all this data and all the documentation that we find very precious are collected thanks to all the institutes and the national experts. And again, finally, we thank you for your attention, and you can find also on our website the time of use and our contacts if you want any information or to talk with us about projects that we are now starting to develop. Thank you.
Thank you very much, Emmanuelle and Arianna. So I got a number of questions from Josh. Most of them were in fact answered in the presentation, but there might be a lingering one or two. Josh, if you want to pick one of all of your questions, do you want to ask it now since you have the microphone?
Sure, I would just love to have someone write more of a critical essay about the different sources. I think INED's maybe not in a position to do this since they're working cooperatively with each data provider and just kind of take, they don't want to be criticizing or commenting really on the quality of the data perhaps. But as a user, I would just love to understand why the data looks different for the different countries and have someone think about this. And maybe INED's in a position to do this, but at least the current documentation for me is kind of what the individual statistical agencies are saying, and that doesn't help me understand why there's more reporting at different ages and things like that.
Emmanuelle, do you want to?
Yeah, actually, we discover more and more elements to explain why when we go through the data, when we look at how it's spread day after day of the pandemics. And we actually go deeper and deeper in the report, and we can find, and this is actually in all the reports when they define exactly what are the data coming from. You find out that some of them are quite partial, and you don't know exactly what kind of representativeness of the death they are publishing. So we don't have an exact answer to your question, but I think one of the main project that we want to develop on this database is exactly how the information system is working in all those countries and how far we can take some information from one country to help the other country to develop more efficient system to have more comparable and more representative data in an urge if another pandemics would happen.
Wonderful, thank you.
Thank you, Emmanuelle. So there is a question from Will Dow on excess death, and I suggest that you keep that question for after the next presentation. since Vladimir is working with others at MPIDR on this database to provide baseline information just to do that kind of things. And then there's a question from David about mortality assumed by cause of death in Italy and Spain after 65. And that's not going to be answered by this presentation. So again, I suggest we keep that for later. So without further delay.
Excuse me,
Yes?
Magali, I just a question about, can we pull all the data together? I think that
Yes,
Josh,
so I answered, yeah, go ahead, but I answered that.
Yeah,
but...
just to add that there will be very soon a pool data set that would be available on the website in order to have all these data gathered all together. Yeah,
as CSV format. Okay, so without further ado, I'm gonna give the microphone to Vladimir so that he can present the next talk. Thank you, Vladimir.
Once again, thank you very much for opportunity to talk at this brown bag. Yeah, okay. It's named a quantification of COVID-19 pandemic, excess mortality plus STMF data series. So this is the resource that we have to quantify the pandemic at the Max Planck Institute. So this presentation was by Dmitry Zhdanov, Ainhoa Alustia-Galanza, and me. So as you know, the dominating type of information available for quantifying the pandemic is information about confirmed cases and so-called COVID-19 deaths. So, of course, people are very concerned by the scale of changes happening to them. And they want to know they want very much to know on daily basis what's going on, what is happening, what are the changes. And these resources, they respond to this demand very well. So this is a John Hopkins resource on the pandemic, so-called World Meter, and daily series at the European Center for Disease Prevention and Control. All type of information is the same. And if one tries to present this information in a simple way, like one European Commission document, so it's just a rise and it looks very logical. So accumulated numbers of cases of disease. So Italy and Spain, then there is a gap, then France and Germany, another two big countries, and then countries with smaller populations. So everything is fine, an easy image. But if one tries to do a very simple manipulation, like, for example, to present not the absolute numbers, but to divide them by population, and to put cumulative death rate for COVID-19 deaths against cumulative morbidity per 1 million population, then there is this, diversity. And if one, for example, draws a vertical line here, that it's possible that one and the same number, the same cumulative morbidity corresponds to radically different mortality from COVID-19. So there are many problems in this. For example, if you compare Germany with France, there's nearly 10-fold difference in mortality. corresponds to the same cumulated prevalence, not prevalence, but morbidity of COVID-19. So the problems with registration. There's hardly comparable ways to register disease and death. Intensity of testing is very different. Countries take on very different strategies with respect to detection of disease in the population. With respect to registration of COVID-19 as a cause of death, for example, there is a divide between one group of countries like the USA, the UK, and Germany, where there's positive testing plus information on chronic diseases and their severity, and France, Italy, and Spain, where the positive test is a decisive condition for registering deaths from COVID-19. Another problem is that these counters and the current registration of COVID-19 deaths differs in many cases from the final registration of deaths and from how the final statistics on causes of death would look like after the end of the year. So, here we exploit the old idea, the assessment of short-term all-cause mortality fluctuations and excess deaths. So the two examples from Russia, so a trend and then fluctuations around this trend for deaths in 2004 to 2015. So mortality is going down, you see it, but there are major fluctuations. And this study was about this major flu epidemic of 2015, it's here. And another example how useful this information may be is this deaths by month in 1956 to 1980 in Russia as well. So you see that it's more or less constant until a certain moment, and then it suddenly starts increasing. And by the way, this increase was lasting about 40 years. And what happened? It's a change of the leader of the USSR in October 1964. So, characteristics of this method. This method is not affected by cause of death registration, obviously, by subjectivity of diagnostics. Then it measures the total impact of temporary changes on all-cause mortality, direct or indirect. In other words, if during the COVID pandemic, intensity of work of the normal healthcare system, of diagnostics of cancer, of planned CVD operations, and so on, if it lowers, then mortality from other causes of death other than COVID may increase, and this will be reflected in all-cause mortality. So direct and indirect effects. Another thing is that it depends on timing in the work of the registration system. So, and usually in weeks is suffering from incompleteness. And possible harvesting effects, I cannot explain it further, but this is very well known effect when actually after elevation of mortality, it may go down very much or vice versa. After a period of low mortality, mortality might increase. So the all-cause mortality surveillance systems existed before our database. So the two major examples and only examples: Euromomo project and weekly data provided by ONS in England and Wales. So the observed weekly deaths are compared to expected deaths. In Euromomo, the expected deaths are produced by a statistical model with harmonic terms. So it means that there is an expected seasonal fluctuation in deaths. and excess is being determined against these expected fluctuations. Unfortunately, the project does not provide data, the original data on deaths or death numbers or death rates. It provides some graphics with z-scores, and it's quite hard to see what stands behind these z-scores. The ONS is much simpler and more transparent, so expected deaths averages of the previous 5 years for the same week, and it provides complete data on registered deaths. So what we do is, it's a new part of the human mortality database. In this rectangle, you have actually everything. So all links to the data are here. And it is said that it's short-term mortality fluctuations data series, STMF. So it was launched on the 19th of May this year. And today it includes 15 developed countries. Data mostly covers the 2000s and 2010s. Types of data, death counts and death rates by year, week, age group. We have 5 aggregated age groups. Standard 7 days weeks according to ISO 8501 guidelines. Data format, Excel, multiple worksheets, 1 country per worksheet, and a CSV file with pooled information for all country years in 1 file. Then there is an explanatory text, background input, output data methods. All the original input data is also provided in a standardized format, and we also provide metadata, which gives further details about origins and features of data for each country specifically, separately. This is a summary of countries already included in the database. So from Austria to the USA in alphabetical order, and the periods covered, they are shown here. So our data sources are either national statistical offices or the Eurostat in some cases. And England and Wales is shown here in a different way. And this is because there is an important divide between this country and other countries. In all countries, data on deaths is by date of occurrence. And only in England and Wales is the data is by date of registration. It may happen that we will be able to replace this data for England and Wales by the date of death. We will see. There is some opportunity. I've heard of that. Now, a few country series. I show here a few examples how it looks like, how the data looks like. So this is Germany, and here we see, this is COVID deaths in 2020, and some of the previous flu epidemics. For example, this one, 2018, 2015, heat waves are actually looking more threatening than this epidemic, but of course, it is conditioned by a huge set of measures against the virus, which were taken by Germany. But still, one can wonder actually why so much is done now and so little was done a few years ago against the flu. Then England and Wales, a very different picture. So this major epidemics of the past not so prominent, and we see more than doubling in deaths. And a few other countries like the USA, here you see a data problem because in the USA, the data building is a little bit slow. So data for the very recent weeks is highly incomplete. And this is Spain, a major epidemic, once again, more than doubling in deaths. Denmark, so the epidemic is within the range of seasonal fluctuations, nothing special here. And Sweden, an intermediate case, it's difficult to see here, but in fact, this one is much less important than the Spanish excess mortality. So Sweden is in between countries not affected by the epidemic and severely affected by the pandemic. And the final thing I wanted to show you, that's a list of countries in pipeline. So you see that we have quite a lot of countries, and especially about France. Hopefully we will include France very soon. The difficulty was that one had to produce French weekly death data out of huge individual death files provided by the INSEE, but this work is now nearly completed. Yeah, thank you very much for your attention. Some picture from the Baltic Sea.
Thank you very much, Vladimir. That was pretty clear. We've had some questions in the chat room, but they've been answered by your two co-presenters, Ainoa and Dima. So in the interest of time, I suggest we move on to the third presentation, and then we can come back if there are additional questions after at the end of this last presentation. So Farida, do you want to go ahead and share your screen?
Sure. Hi, everybody. All right. So I'll be discussing the provisional COVID-19 death counts that NCHS produces. I guess, before I start, if you're not already aware, so NCHS, the National Center for Health Statistics, we are part of the CDC, but our death counts are derived from death certificates, whereas the main CDC webpage produces, it releases death counts collected in a slightly different manner, which is directly from states through a different reporting mechanism. So my talk is solely going to focus on the data quality and data delay issues involved with the National Center for Health Statistics mortality data. So as part of our coronavirus, our COVID-19 surveillance, I'll kind of go over this because I'm sure you're all familiar, but just briefly, so we include deaths with COVID-19 as the underlying cause or contributing cause. And we also include deaths with confirmed or presumed COVID-19. The data from death certificates that we include are the ones that were received and coded with ICD-10 codes as of the date of analysis. The data are incomplete. They do not necessarily include all of the deaths that occurred during that reporting period. And the counts for prior weeks are revised continuously as new data come in. We update our website daily from Monday through Friday, and we have additional variables that we update on a weekly basis. Here, I have a table of the different kinds of data that we currently produce. We're constantly working to add more detail, more information for folks such as yourselves and other researchers to be able to analyze the data in different ways. But currently we do daily updates of COVID-19 deaths and total deaths. And we publish those numbers by week. And also, sorry, and when I say by week, that's by the week the death occurred. And we also produce cumulative counts. We have that on the national level and the state level. And on the sub-state level, at the county level, we produce, we update that information on a weekly basis. We also provide information on sex, age, race and ethnicity, place of death, and excess deaths. And then we also have some data on specific causes, leading causes of death. That's looking at underlying cause of death, as well as comorbidities that are present along with COVID-19 on a death certificate. And one final note, we have not yet started publishing information about external causes of death, so injuries, suicides, homicides, et cetera, because we have a documented lag in report. We know that the data come in on a lag, and so our precedence is not to publish the data until 6 months after those deaths have occurred, so that we're confident that we have enough of the data to say something meaningful about it. So this is a dashboard that we have up on our website that kind of pulls in all of the data that the data files that we put up currently. And this is just an example, but if you go to our website, you can tab through to look at graphic representations of our data. And then this one is, this one catches a lot of people's eye because it shows the counts by the week that the death occurred and by the age group. And you can also select through to look at male and female deaths. So understanding a little more about what these death counts mean. When we're talking about the cause of death, there's often multiple causes of death written on a death certificate. And in most cases, COVID-19 is the underlying cause of death. But when we're publishing our counts, although NCHS typically with our data, we usually focus solely on underlying cause of death. With this pandemic, we want to make sure that we have an accurate representation of all the deaths that involve COVID-19, period. And so we also include deaths, which are 6% of the deaths, of the COVID-19 deaths, where it is not listed as the underlying cause. As I mentioned before, we include confirmed or presumed COVID-19. So that does not require lab confirmation. But if on the death certificate, the certifier has written something that says pending lab results or awaiting lab results, if we know that information is incomplete based on what the certifier has written on the death certificate, we will not include that in our death counts. And we'll update that, that death certificate or that record when we get more information. We aggregate by the week the death occurred. Many of the other sources out there, New York Times, Johns Hopkins, typically aggregate the deaths by when the death was reported or when they became aware of it. And so this is one key difference between the NCHS death counts and other sources. We also report by the jurisdiction of occurrence, and this may include foreign residents that died in the United States. So some other sources we're not, it's possible that they might only, that they might be including it by the decedent's place of the state where they reside versus where they actually expired. And again, to note that the counts are continuously updated. Some other considerations. So when comparing death counts between NCHS and other sources, we recognize that our data are incomplete. We're currently about 2 weeks behind other sources. And I have some graphic representations of that in the following slides. The completeness of data, of death certificate data, varies by jurisdiction. It can vary by week. It can vary by cause of death. There are known delays in reporting, starting from the certification of the death and then how that data is submitted to local and state health departments. And then finally, once it comes to NCHS, there's another week or so of delay for us to code that data with ICD-10 cause of death. And one note, although I think the focus of this conversation of this talk is more about comparing between nations rather than within the United States. But if you are looking within the United States and trying to compare states, you should keep in mind that timeliness and reporting vary by state. Factors affecting that death lag, the data lag, as I mentioned before, external causes of death have more lag. And there are delays by jurisdiction. So 63% of US deaths are reported within 10 days. But different states have different, some states are known to lag more than others. There's also at least a week or so lag that it takes for us to code that death and for that death to be available for us to for analysis in the surveillance platform. So this is a chart that this is an old analysis, and we hope to actually publish an updated version next month or in the next month or so. But this is looking at the delays in the cause of death reported on the death certificate. So drug overdose deaths, injuries, suicide deaths are, they typically lag behind natural causes of death, and heart disease is kind of that placeholder for natural causes of death. And so since we've updated the analysis, I couldn't include the slide because it's not published, but I can say that timeliness has improved across the board. So this graph, the data are available more quickly than they were in 2015, 2016. And so here I've got the one of the main tables that we update on a daily basis that shows the count of deaths by the count of COVID-19 deaths and all cause and a couple other causes of death by the week that the death occurred. And I want to draw your attention to the fourth column where it says % of expected deaths. Well, let me go back before you pay attention to that part. So we include this for a couple of reasons. So what we do is we look at the number of deaths in the past 3 years. Okay, I'll go faster because I have more interesting things to present. But basically, this is what we would expect. But there are some things that we can see in the expected deaths and compared to the data that we're seeing. So that little dip where we don't have 100% of the expected deaths, that reflects the 2018 flu season, which was pretty bad in the early weeks of February. And then you
We lost you, Farida. Uh-oh. Technical issue. Sorry about that. Let's see. If you hear us, maybe you want to disconnect and reconnect. That's too bad. Well,
Magali, could you
yes.
tell us just a little bit about what position our speaker has in MCHS? Does she work in Bob Anderson's group? Is she one of the
No, my understanding is that...
Is she one of the supervisors?
My understanding is that she works with Jennifer Manance and Paul Sutton.
Farida is back.
Hi.
Oh, hi, Farida. Thanks. Okay,
Hi.
so let's
Sorry,
go back
I
to
don't
the
know what
topic.
happened. I'm sorry. Should I go ahead and continue?
Yeah, you have to share again your screen.
Okay. Sorry, I'm not sure.
I'm sorry you had this problem.
Okay. Sorry about that. And okay. So let me skip over this slide because I want to show some other stuff. So this this chart shows the how the data are received over time, and it shows by the lag in days. So so each section of this graph represents the death occurred. And so over time, we are receiving more and more deaths. So for the beginning week of April, you see that it's starting to level out. The second week of April, the death the week ending in April 11th, it's still climbing, but it is the number of deaths is starting to slow down in terms of how many deaths we were receiving each day. And this is a slide that I tend to keep up because we want to understand how the data patterns and the data flow of how we're receiving.
Farida, could you use your mouse just to walk us through one of the panels so we understand what it's saying?
Sure. I'm not sure if I know how to do this because this is actually a video, like I took a screen video, but so.
If you just point your mouse at the bars and explain them to us, that would be great.
Sure. Okay, yeah. So this would be, the zero lag, that would be the first day that we began reporting deaths for the week ending April 4th. And then each subsequent bar would represent every day since that first day that we are updating the number of deaths. So initially we started off with just a handful of deaths. And then by 20 days after that, we first started reporting deaths for that week. We had about 8,000 deaths. And then here at 40 days or about over a month after that week that we started reporting about, we have about 9,000 deaths. So, and then for other weeks, we already know that some weeks are worse than others, particularly the week ending in April 11th and in April 18th. So the deaths are still increasing. So if those hadn't been such, I guess, deadly weeks, the data probably would have started dropping, leveling off by now. But we're still receiving death certificates for that.
Thank you so much.
Sure. And so this one, I know I'm short on time, so I wanted to focus on this one. So here I've plotted the number of deaths that were reported by the New York Times and by the website usafacts.org. And I selected usafacts.org because CDC works with USA Facts to bring in some of their data on, I can't remember the name of, I think it's like COVID tracker. There's one website that CDC has that consolidates a lot of death, case and death information. And so I wanted to show that if we're focusing on the week of April 11th, so all of the deaths that happened up to the date of April 11th, New York Times and USA Facts reported over 20,000 deaths for that time period. When we first started reporting deaths for that period of time, we were only reporting about, I think it was like 6,000 deaths. And then over time, as you see, each day we're getting more and more deaths. Eventually, so after about 2 weeks, our numbers align, but then as you see, as time goes on, we're showing more deaths. Whereas if you looked at, say, New York Times at their, if you download their death count data, since they're doing it by the date reported, you would just see, if you looked at April 12th, for instance, you would just see this number, this number, and then you wouldn't see these extra deaths that have come in since then would fall under subsequent reporting dates. And I think this is our last slide. This is just our website where you can find a lot of the information that we have available. So. Should I go ahead and stop sharing?
Sorry. Thank you, Farida. There were a lot of questions. That was clear presentations, but there are lots of issues with the US data as in other countries. For instance, well, many of these questions were already answered through the chat, Please wave to me if, well, Josh, you had a couple of questions which were not answered. Do you want to ask them? No?
Sure.
And then we have Claude.
Yeah, let's start with Claude.
Okay, go ahead, Claude. You have to unmute yourself.
Yes. So my question is, do I correctly draw the implication from the CDC data that deaths are probably declining faster than implied by the popular reports, and we're higher earlier? So there was a higher peak and we're now on a faster downslope than those of us who consume the New York Times would believe. Is that a fair assumption?
No, I would not say that, because we don't have enough data. The data are still coming in, and there's we're in, I'm trying to remember, orient myself on the calendar. We're still in May, and it will take a couple more weeks for us to really feel comfortable with the number of deaths for early May. I think there does seem to be a slight decline, but it's too early to tell, and that's not something I would go on the record and say it is an actual artifact. Yeah.
Thanks. There was a question from Ron as well.
And this is Josh again. I have my question when Ron's done.
Okay.
Okay, well, I'm wondering whether the different places reporting COVID deaths might involve different delays in the reports to NCHS. In particular, whether the timing of reporting for nursing homes might be different than the timing of reporting by hospitals. I'm interested in the fact that the US age mortality curve seems less steep than in almost any other country we've looked at, and whether that might be part of what's going on. Thank you.
You know, that's something that we don't have a lot of data about in terms of the data flow from the different places, or, you know, involving the different places of death, but that is something that we could probably look into, and it's a very good question.
I actually have a follow-up comment on that, and I'm wondering if the fact that the curve is not as steep by age in the US as elsewhere could be because there are more comorbidities, especially obesity, which is a major risk factor for COVID-19 in the US compared to other countries. So that's something we won't be able to answer for a while, but I think it's worth looking at that too. So there was a question by Will. Go ahead, Will.
So I was wondering if you could share the slides that have the information on the external lags in reporting. And I see someone posted a link to a related report, but are there sort of more details on the historical lags on those external deaths?
Yeah, we have two. So there's a report, the slide that I shared is a chart from a report that we put out in, I think, 2017. And that looked at the different causes listed. So suicide, drug overdose, and heart disease, and then all injury. We have a report, I think in 2018 that we put out that focused solely on suicides. And we have another report, I think it came out in 2019 perhaps, on focusing solely on drug overdose deaths, and then more granularity on those drug overdose deaths. And then so I think late June, probably early July, we hope to have an update to that original analysis. And this update will also focus on delays with age, sex, and jurisdiction.
So just a clarification here, Farida, is it because for external causes there needs to be more investigation, including from the Justice Department?
Yes, yeah, that's exactly. So there could be the need for autopsy analysis, there's testing, and then other investigations that might involve law enforcement.
So those are not included at all in the total deaths right now?
Those are, no, well, they're They're included, but they're not. So if we've received that death certificate, that number is included in the total deaths. But we have a couple files out right now that that show various leading causes of death and the death counts for those, specifically like heart disease, sepsis. There's like cancer, and we've received requests to add that external cause data, but we haven't yet because we don't. So you don't have the specific counts for external causes, but those deaths, if we've received them, are included in the total number of deaths.
Thank you, Farida. So officially,
this is Josh. Can I ask my question?
Well,
or am I too late?
Can I just say that we're now reached the official end of the meeting, but we can abuse the timing since we're remotely connected. Can the speaker stay for another few minutes if there are additional questions? But everyone who needs to go is excused. So go ahead, Josh.
Yeah, so my question was about the CDC public release and researchers. Is there, can researchers contact you and get more detailed data, or are we basically limited to what you are able to release officially? Is there any way researchers can help you? Is there any way to get access to data that's not publicly available? Kind of a question of interface, researchers and CHS at this point.
So we cannot provide specific data requests to any individual, even within CDC, a different department, or even the White House. So we cannot, we can't release data to one group and not do it publicly. If there are specific concerns that you have or things that you want to look at, you can contact me and I can put it in our list of considerations where, you know, we kind of have a wish list of things that we'd like to put out. Sometimes there's reasons why we can't put it out. If there's too much granularity, for instance, we have to suppress a lot of it for confidentiality purposes, but you can always contact me and I can let you know where we stand on that.
Great. So you kind of have a wish list and then you present it to everybody at once is the idea. That's great to know. Yeah. Can I ask about the suppression too? Now, suppression is obviously kind of linked to the whole mortality system. You see it in CDC Wonder and things like that. Has there been any discussion at NCHS of maybe changing the rules for COVID-19, which doesn't appear to be stigmatized in any way?
No, no. I don't think that that rule will be relaxed. So we don't do the suppression on the national level, but it's at the subnational level. So at the state level, any cell counts less than, or between, I guess between 1 and 9, you have to suppress. And I don't think that's going to change.
Thank you.
Thank you for that. Questions about the other presentations? We can go back to the 2 databases that were presented if you have questions. So
I actually have another question for Farida.
Go ahead, Robert.
Unfortunately, you got cut off right in the middle of discussing that table, column 4 of your table, which was labeled excess deaths. And I could see that there were numbers that looked like 98%, and then there were numbers that looked like 133%. And you got cut off at exactly that moment. And I wanted to find out what that 133% meant.
Sure. So that 133% means that so we calculate how many deaths we would expect per week. Usually it's around 5,000 deaths per week. In the winter months, it's more than that. So for that particular week, based on the that same week in 2017, 18, and 19, we've received more deaths than we would expect based on those 3 years of data, you know, that based on the previous pattern. So
that was a 3-year running average of that week, and you're comparing to the mean.
Yes.
Thank you.
Okay, there is a Pixel 2 question, or?
Sorry, I had a question. This is Josh again. In thinking about excess deaths, if we have fewer than the average in February and more than the average in March, then how do we conceptualize that? Is it on net zero? Do we just take the excess? Do we infer something about selective processes of culling and scarring? It's a question for I guess Vladmir.
Oh, sorry.
Vladimir, you're on mute, so we can't hear you.
I'm not sure I understood, Josh. Can you repeat it?
So when we think about excess mortality, we usually think about deaths being more than the baseline. And so we just subtract the current observation from the baseline. If over the course of months, if some months it's below and some months it's above, or let's say in October we have fewer than the baseline, should we be subtracting that from the excess deaths, or how do we think about this? It's a more broad theoretical question about how to think about excess mortality.
So I think the question is, let's say that, and we know that in 2020, the flu epidemics was much weaker than in previous years. So if we calculate COVID mortality by looking at excess death, we might underestimate the impact of COVID-19 mortality, because this year we would have had fewer deaths than last year in terms of influenza, for instance. Do you get that?
Thank you, Magali. Exactly.
Yeah, it's well. I'm not sure I have a good answer to this one because it's this. It's just like some simplified standard approach, and you should apply your sense of humor to the results. So, for example, why do we compare deaths in April to deaths in April, or deaths on second week of April to second week of April? Why don't we compare deaths in April to deaths in, I don't know, February 2018? Because we had an epidemic at that time and we have another epidemic at this time. So, I mean, that's, a real analysis of this should be something like analysis of dynamic cross-sectional time series, but it's useful to have some measures of excess. So if we agree, that we accept such a difference as a measure of excess, and then the second step would be to understand why this measure is like it is, So, because it may be that it's a real epidemiological situation is behind it, or it is because we measure it this way, So there is no really answer, and there is a way established by the ONS. So for some time being, we follow this simple way. And we will apply it to different time series. And afterwards, we will find a better instrument.
Farida, you seem to have some contribution to this question.
I think Vladimir answered, kind of said some of the things that I was thinking, that, we're looking, when we compare, we want to compare to that prior week. In early February, we knew that COVID was not widespread. The COVID mortality was not a main issue, even as we get, more death certificates, or if there are more, if more posthumous testing of deaths, we just didn't see that that increase of deaths at that time. And we know that there is an uptick of deaths in April and in March, So I would refer you, I think you are familiar, but I would refer you to our excess mortality page, where a colleague who has a lot more experience in modeling deaths than I do, she has, she's kind of laid out exactly how we've come to those numbers and how we're doing it. But I would say if you're looking at excess deaths, you have to factor in the time of year that you're looking at, because deaths are seasonal.
Thank you. So I don't see any additional questions, and it's already quite late, especially for our European colleagues. So I suggest we end this seminar here. I want to thank again everyone for participating, and especially the contributors. And don't hesitate to get in touch with additional questions if you have some in the next few hours or days. So thank you, everyone. And I guess we'll hear from the Department of Demography about the next brown bag, which might be in 2 weeks, I guess. So have a good evening or afternoon. And then...
Merci.
Okay, bye, everyone.
Bonne soirée.
Bye, bonne soirée.
Merci.
Bonne nuit.
Bonne soirée à vous aussi. Oui, bonne nuit surtout.
Super interesting. So I was just wondering, is there thought being given to incorporating some kind of adjustment into the incompleteness when you, is that high on your wish list to propose an adjustment so that you don't have the downticks at the end?
No, we're actually, I mean, well, we're kind of actually thinking of getting away, doing away with it, because particularly for older, you know, the older weeks, the utility is kind of, you know, it's, you know, after a certain point, it doesn't make as much sense. The reason we initially included it was so that people see that, you know, when they see the numbers are very low for those recent weeks, that they look at that percent expected and say, oh yeah, that's because they haven't received all the deaths that they should. Mm-hmm. And that's the main reason that we're keeping that number there. For at least for this page, we want this, when I say this page, I mean the provisional counts page. We haven't done any manipulation to the data, and I think we want to keep it that way, that we put out the counts as they are and let folks interpret it accordingly. So there are a couple other files that we put out. So there's a file with the leading causes of death that we put out weekly counts. And so for that file, we have decided to basically cut off that last week. So or I guess the last 2 weeks of data. So we just don't, you know, I guess we're publishing that data on a lag as well, if you think of it that way. But that's kind of the extent of what we wanted to do. I think in terms of leadership, and actually I heard you as I was having my computer problems asking if I work with Bob Anderson. Yes, he's my supervisor. So I work in his group. But so my, you know, in the discussions I've had with leadership, including Bob, including Jennifer Maddens, et cetera, they've been of the opinion that, you know, we want to make available as much data as possible, and put out all the caveats that we can, and let people know what this data might mean and what it doesn't mean, and, you know, ways that you probably shouldn't interpret it, and let people take it, hopefully with those caveats when they're analyzing it.
So I also have a question about, sorry, typically the death certificate data become available as part of the multiple cause files about, well, usually like around December of the following year. So the 2020 data would become available in December 2021. Is there any plan to try to accelerate that timeline because of the current, you know, epidemic?
No, and not that I've heard of. I think it's probably too early to be having those conversations, but it's also a tremendous amount of work.
Yeah, I know.
Files. And, you know, beyond the work, you know, I'm just thinking about the work that, you know, folks in my office do to prepare the files, but the real limiting factor is the receipt of that data. So we're still, we don't close out that data year until about June. So, you know, from June to, I think as October is how long it takes to prepare the file. And then I think usually by November, December is when they're able to release it. So yeah, I mean, if we got the data faster, we could put it out faster, but we're still kind of, you know, we're working with states to get the data, but I don't know that that's going to move up a whole lot.
And I had another question about the difference between the CDC numbers and the numbers we see on the medias. So you had one slide about that, but I wasn't clear about so when the Financial Times announces more than 100,000 deaths in the US and you have less than 80,000 on the website, is it because they get their information directly from the states? How do they get the numbers?
Yeah, so there's different ways that people get the numbers. A lot of the local and state health departments are putting out their own counts. And so there are, from what I understand, there's some tools that kind of scrape the internet for these kinds of files and then combine certain publications, like I know New York Times, according to their website, they do this where they have people following up individually, verifying deaths with the health departments. CDC also does, well, CDC has, so if you're thinking about the main CDC, their cases in the US counts. So their death count is higher than ours because they're also getting it straight from the
states.
Yeah, from the states, but through a different reporting mechanism. So there's so much data out there and there's a lot of different people gathering it in different ways. We just try to be transparent as we can about what we have because we can't really explain how others get their data.
Can I ask Serge's question, which was just, we noticed that when we were downloading data on the cumulative counts that you only had the most recent file available. Is there a way to get the past one so that we can kind of difference it out to see what's happening over time?
We don't do that, just because I think it's it's a precedent that we've set with our provisional data, and we've done it for years. As we like even with the NCHS flu data, we don't give out the files that we've previously had. There's no actual reason. We just don't do it on precedence, but I think there are people out there who do collect it.
Yes, I have collected every single file, every day it's changed since April 12, I think, because I am a contributor to the INED database for the US. So Josh, I can send you that.
Okay, so we want the counties, the county counts for every time.
Oh, and some of the tables that are now available were not available initially.
Yeah. Okay,
so
great.
I think that's the case for the county. But I can.
Can I ask one more question? Just getting back to the lags and cause of death. So when I look at the weekly provisional data table that you release, there's a count for all deaths, and then there's natural causes, and then a number of subcategories for natural causes. So when you said that there's an injury death that is still being reconciled, what the exact cause is that included in the total number of deaths, but it would just be in a unknown cause of death category if you had that, or generally are they not included? When you were showing the graph of the proportion of the injury deaths that are reported after 12 and 24 months, is those just the proportion that have a cause of death coding, or is it the proportion that are showing up in total deaths?
Kind of both. So I think for, if the death certificate was submitted to us and they say pending investigation, that would be included in our total deaths. And that's more often the case now nowadays. But a few years ago, states had a tendency to just hold on to the death and not report it at all until they had the information, and just send all of those at once, like at the end of the year. So with, say 2015 data, that there might have been more of a proportion of deaths that were just not sent in until the end of the year. But there were still deaths that were they were sent in with a cause of death that says pending. So nowadays, I think because we encourage the states to send in the death certificate no matter what, just send us the death certificate, say pending, update it later if you need to. So we really want them to report those deaths quickly. That, you know, so we probably are capturing that, you know, that the death occurred, but maybe not why it occurred.
So we might have 90% of the injury deaths from April at this point, for example.
Right, but we just don't
Data
know.
release. Yeah.
Yeah.
Okay. Thank you. That's really helpful.
I hate to pressure you because you've already been on so long, but I had one more question just related to some work we've been doing on the racial and ethnic counts. Can you tell us about your decision-making process when you decided to do the geographic weighting and how you thought of that and what future plans there are there?
Yeah, so when we had been getting pressure to, you know, to put out ethnicity data pretty early on. And at that point, a lot of the spread of a lot of the deaths were concentrated in the New York City, New Jersey area. And we knew that that population didn't necessarily reflect the racial and ethnic distribution of the United States. And so we didn't, whenever we put out data, we want to make sure that we're putting enough context around what that data represents so that somebody else can interpret it. And I think the thinking was that, you know, if we just put out the counts, you know, the raw counts or the raw percentage, that doesn't give enough context about the places where most of the deaths, the bulk of those deaths were occurring. And, you know, also when we start putting it out by, well, actually, I mean, at the same time, we were putting it out by state-specific data. And so we also wanted to reflect, you know, the racial distribution in that state. And that was really why it was in an effort to be transparent. So we provide both the weighted, but also the unweighted so that you know what it is, but we also wanted to show that, show the distribution the racial distribution in terms of where the deaths were actually occurring versus the whole entire United States.
Was this a method that you had to invent for this purpose, or was it something already being used in other contexts?
Yeah, it was a new method.
Okay. And what about age standardization?
We have not done any age standards. We just put out the counts.
Thank you.
Okay, well, thank you very much, Farida.